So we were suggesting that the liver, despite not being an endocrinal organ, it normally plays a very important role when it comes to the endocrine, in that some hormones need to be metabolized for us to see their active form. So minus the liver, we can also have a lot of endocrinal issues, and a lot of hormones tend to be metabolized into the liver to their inactive form. So minus the liver, you can also suffer excesses of some of these hormones. So when you talk of the endocrine, so we suggested that it can be compared to the nervous system. So the endocrine and the neuroendocrine hormones interacts with one another in order to maintain the hemostasis. For example, the adrenal medulla and the pituitary secretes hormone in response to neural stimuli. The multiple hormones system have a significant role in regulating almost all the body functions, including metabolism, growth, development, water, electrolyte imbalances, reproduction, and behavior. So these are some of the specific roles that we'll be anticipating with these hormones. So for example, the general metabolism, growth, development, water, electrolyte balance, reproduction, behavior. Most of these physiological processes are dependent on the hormones. And of course, sometimes when you talk of the hormones or the endocrine, we can extend it or maybe link it to the nervous system. This is because there are some neurotransmitters that also can have the hormonal role, and some hormones acting as a neurotransmitter. A good example will be the adrenaline, noradrenaline that are normally produced at the adrenal gland. So these are the types of hormones. So for example, you are able to see the various types of hormone depending on the organs where they are being produced, or the endocrine organs. So for example, the hypothalamus are expected to produce the thyroid releasing hormone, the corticotropin releasing hormone, the growth releasing hormone, and also we should be able to produce somatostatin. So the list is long, where you will be having a specific gland and a specific hormone that should be able to be produced. So maybe what you need to remember is that most hormones are normally produced in this manner, or rather respecting this axis, even though we know that it is not compulsory. So the hypothalamus likely to be a major stimulus, either releasing hormone or inhibiting hormone. So these have an effect on the pituitary gland, which might influence other organs, endocrine organs. So a good example will be maybe the ovary or the testis, which can be stimulated to further release something like estrogen and progesterone. While there are other group of hormones that normally operates independent of this system. So a good example would be the pancreas, where the stimulation is heavily reliant on the level of blood sugar or the level of glucose. So without getting too much of the communication from either the hypothalamus or the anterior pituitary gland. So that will be apparent as we move along. And also some organs such as the GIT. So you are able to remember the specific hormones that were produced locally to be able to influence the local physiological activities in the GIT. And the heart can also be considered an endocrinal organ. Remember the production of the anti-natriuretic peptide, especially when the cardiac muscles, specifically of the atrial, are subjected to stretch. So when you think of an hormone, it is in a group of what you can call a chemical messenger. So the bigger umbrella for the endocrine will be the chemical messenger. So that means that We can also have some other types of chemical messengers that are somehow related to the endocrine. So what makes a substance an hormone or an endocrine hormone? It means that it should be able to have a specific attribute, and that specific attribute is that these are normally released by the glands or specialized cells, and then after the release, they get into the circulation, and then while in the circulation, they are able to influence target cells at another location. It will be a nearer location or at a distance, because once an hormone gets into the bloodstream, it is able to influence many other target cells. So that is what qualifies a chemical as an endocrine hormone, even though other chemical messengers are things like neurotransmitters. So as you might have known, neurotransmitters should be released by the axon terminals of the neurons into the synaptic junction and act locally to control the nerve function. So you know that in the nerve communication, we normally rely on the electrical energy or electrical propagation. But at least with the neurotransmitter, it is able to convert that electrical energy into chemical energy, so that another neuron takes the signal into electrical. So there is no direct communication between the neurons, and the neurotransmitter normally plays a major role for the communication. So we also have the neuroendocrine hormones. So this means that there are some hormones that have both endocrine and neuronal property. So a good example are things like catecholamines. We also have paracrine. So you'll be able to see some hormones will behave in a paracrine fashion or in an autocrine fashion. So what specifically does paracrine mean? So this represents the type of chemical messengers which, when secreted by our cells into the extracellular fluid, they are just able to act on the neighboring target cells. So they don't need to get into the bloodstream to affect a distant cell. They can just be released and affect the neighboring cells. An autocrine, a chemical messenger which, when released into the extracellular fluid, it just affects the same cells that produce them. We also have cytokines. So these are normally peptides secreted by the cells into the extracellular fluid and can function as an autocrine, paracrine, and endocrine hormone. So we'll be able to see some endocrine somehow functioning as autocrine and paracrine. So a good example will be the pancreatic hormone. That will be our first. So as we proceed, it is good for you to categorize all of these hormones into classes. So for example, we have the protein and the polypeptide. We have the steroid derivative kind of hormones, and we have those that are derived from tyrosine amines. So why is it important for you to know the general classes of an hormone? This is because different classes are likely to have a specific way of production, or maybe the synthesis. They are likely to have a specific way of release, and sometimes they are likely to have a specific way of transport, not with a specific molecule, but in terms of whether they are water soluble or lipid soluble. So this normally has a role when it comes to hormone, especially if you put the liver into context, but we'll be able to see that. So for example, we have hormones that can be considered protein or polypeptide. So this is if you analyze their molecular architecture. They are normally protein and polypeptide. So a good example of these hormones are the insulin and the glucagon, those specifically produced by the pancreas. A good number of the anterior and the posterior pituitary glands are also proteins and polypeptide. The parathyroid hormone are normally again a protein and polypeptide, and many other hormones. So So this should be able to tell you that if something is protein and or maybe polypeptide, you know the normal process of protein synthesis, whereby ordinarily you anticipate the process to start at the DNA, where there is some form of transcription, and then translation, where this is relayed by the DNA, and then to the specific chamber where you should be having ribosomes attached to the endoplasmic reticulum. So that is the rough endoplasmic reticulum. So this is supplied by amino acid, where we are able to use the coded information from the RNA to be able to produce specific proteins. So as the proteins are being produced, of course, from the rough endoplasmic reticulum, so these can be packed into Golgi bodies. And then from there into secretory vesicles, just awaiting their release, and their release is likely to be via exocytosis. So all these hormones that we are suggesting over here are likely to be produced in a similar manner. Let's just remember that. We also have steroids. So example of steroids are cortisol, aldosterone. So these are normally produced by the adrenal cortex. Those produced by the ovaries and the placenta, and of course the testes. Estrogen, progesterone from the placenta, and the testosterone from the testes. So these are normally steroidal in nature. So their chemical architecture are those of the steroids. So one unique property with this is that they normally rely on the supply of cholesterol to the specific cells. So it is this cholesterol that can be utilized to be able to produce now the specific hormones that we are suggesting. And maybe unlike the protein and the polypeptide types of hormone, these are not normally stored within the cells, just like what we had with the secretory vesicles. So in the cells, so let's assume this is a cell that wants to produce one of the steroidal hormone. So we normally have the cholesterols in the cytoplasm. So upon appropriate stimulus, so these cholesterol are normally mobilized immediately to be able to form the specific hormone, and then afterward being released. So the mobilization or the formation of these hormones is normally dependent on the stimulus. But with the proteins and the polypeptide, you'll have your hormone form way before and just packed in the secretory vesicle, are waiting for the appropriate stimulus. So when the stimulus comes, it just stimulates the exocytosis in the protein and polypeptide. But with the steroids, it stimulates the formation, where you mobilize the cholesterol to form the specific hormones that are required, and then of course released. So we have those derived from the amino acids, tyrosine. A good example is the thyroidal hormone. So these are the thyroxine and the triiodothyronine. So this is the T4 and the T3, and the adrenal medullae producing the epinephrine and norepinephrine. So these two groups of hormones are normally derived from the tyrosine. The thyroid and the adrenal medulla hormones are formed by the action of the enzymes in the cytoplasm compartment of the glandular cell. So we'll be able to see that. So unlike maybe the protein and the polypeptide, where it could be having a long chains of amino acid attached together, these hormones are specifically derived from the amino acid tyrosine. So tyrosine is much takes the big chunk unlike with the others. So don't have a confusion of whether maybe this could be protein. Maybe yes, but they are derived mostly from the tyrosine. So we are dealing with a specific amino acid. So that is the fair introduction. So let's just go straight into the pancreatic hormones. Pancreatic hormones and the antidiabetic drug. So of course, anytime you think of the pancreas, as far as disease is concerned, you want to think of the diabetes mellitus. This is because this is a representation of a metabolic disorder characterized by chronic hyperglycemia due to relatively insulin deficiency, resistance, or both. So it should be telling you that maybe to a distant or to an extent you could be having an issue with the pancreas. So if the pancreas is dysfunctional, it means that the production of insulin might be compromised, or sometimes you might produce the insulin but it is not able to act on their receptors to be able to allow sugar to get, or rather glucose to get into the specific cells, into the insulin dependent glucose transport channel. So apart from insulin, we also have some other hormones such as glucagon. So intrinsically, glucagon can be deemed as an antagonist of the insulin. So whereby if the insulin tends to lower the sugars, the glucagon tends to rise the sugar. So these are the two major hormones. But as far as disease is concerned, our major emphasis will be with the insulin. Even though we can have other types of hormones such as amylin, somatostatin, pancreatic polypeptide, it is only that their function are not well established. Even though for the somatostatin, we kind of know its function. Anytime you see the somatostatin, just think of a universal inhibitory hormone. So they tend to inhibit many hormones. So in our context, somatostatin can inhibit the insulin, can inhibit the glucagon. So pancreas, it is not only an endocrinal organ, it can also be very important in the production of a pancreatic enzyme, and that is normally by the pancreatic acids. So we are ignoring that for a moment and focusing on the islet of Langerhans. So the islet of Langerhans are a group of cells where you are likely to have specific cells that are charged with the production of specific hormones. And remember, pancreas is an endocrine organ too. It qualifies as that. This is because you are able to see the cells, and besides the cell, you are also able to see some blood vessels. So these are blood vessels. So that means if the hormones are produced, they are able to get into the blood vessels and of course affect other distant target cells. And that's how it qualifies as an endocrinal organ. So let's explore the specific cells. So in our image, you are able to see the alpha cells, the beta cells, the delta cell, that is, the beta cells, and we should also be having some PP cells for the polypeptide. So islet of Langerhans contain three types of cells. Beta cells likely to produce insulin and amylin at a ratio of 100:1. So obviously insulin is the most dominant in this. We also have alpha cells likely to produce the glucagon. We also have delta likely to produce the somatostatin. So remember, we suggested somatostatin has some inhibitory property, while glucagon and insulin could antagonize each other in terms of their specific role. Maybe not more so in terms of their production, but majorly in terms of their role. So we suggested that when it comes to autocrine, paracrine, pancreas can be one example to demonstrate how sometimes the endocrine hormone can also partakes the autocrine and the paracrine role. So the close interrelation among these cells in the islet of Langerhans allows cell-to-cell communication and direct control of some of these hormones by the other. For example, insulin inhibits the glucagon secretion. So that means if beta cells release insulin, it is able to act on the alpha, and when it acts on the alpha, it depresses the production of glucagon. So that is a representation of the paracrine. We're having something like amylin. Amylin inhibits insulin secretion. So that means beta cell producing an amylin. The same amylin has the ability to again suppress the same cell that produced them, where it is now seeking to depress the production of insulin. So that is a good representation of an autocrine role. So the major division of the chemical messenger, it is mostly respecting the major properties of how these chemical messengers are likely to act. So that the division or the classification is not as strict, having that you can be an endocrine and have some paracrine property, autocrine property, or sometimes cytokine property, even though the cytokine property is very minimal, because most of these are likely to be just peptide and not really polypeptide. So with the insulin, insulin becomes our major point of interest. So we suggested that insulin was one of the protein stroke polypeptide hormone. So we should be having the same mechanism of production. So let's just go straight into our image over here. So that means before the powerhouse, that is the endoplasmic reticulum containing the ribosomes, it should be able to get some instructions from the DNA. So the DNA transcription needs to occur, so whereby the information is being relayed to the RNA, and then from the RNA, messenger RNA, where that can be utilized to be able to synthesize some protein. Why is this important? So this is very important in that we also have some hormones. For example, if I can mention the growth hormone, the thyroid hormone, the T4, T3, so majorly the T3 because it's the active. So, and also even though these others are specific, the other steroidal hormones are specific. So majorly with the growth hormone or maybe with the thyroid, they also have the ability to control the transcription and the translation of many proteins. So suggesting that insulin is also a protein in instances where maybe you are having a low growth hormone, low levels of thyroidal hormone. It means that they might also be able to suppress the production of protein, suppressing the protein synthesis. This is because for you to have a normal transcription and a normal translation process, this process to most places are normally hormonal dependent. So that the level of thyroid hormone increases the transcription and translation. So similarly to what you can see with the growth hormone. So minus these two hormones, it means that the insulin might not be produced adequately, because we actually require these other hormones to work on the background. So which level of the background are this hormone likely to act? It's basically the transcription and the translation. So you are having a similar clinical syndrome where somebody is having hypothyroidism. At the same time, this person having some maybe some metabolic syndrome of diabetes, or maybe low level of insulin. So this should be very obvious for us, having that this again might translate into hyperglycemia. So it is good for you to understand this, because sometimes you could be dealing with hyperglycemia not because you are having an issue with the pancreas, but it is because you are having understimulation with the hormones that should be able to support the background processes. So the process of protein synthesis, and you see from the synthesis there'll be packaging of our protein. So this is packed into the Golgi body. You are able to see the various type of Golgi body, the cis Golgi, the trans Golgi, and of course by the end this cleaves off into secretory vesicles. So while at a secretory vesicles, they'll just be waiting for the appropriate stimulation. A phosphorylation takes place. These attach into the mother membrane, and then our product being released via exocytosis. So one thing that you need to know is that while these hormones are being packed like this, for example, at the rough endoplasmic reticulum, you'll be having your hormone as a pre-pro insulin, or maybe think of it as a pre-pro hormone. So whereas it is being packed through some enzymes that exist within the Golgi body and within the secretory vesicles, so this can be further modified to give us a specific hormone. So as far as chemical is concerned, so see our insulin, how it's transforming. So when it is being produced at the rough endoplasmic reticulums, it is the pre-pro insulin, which it can be modified into proinsulin and then further modified into insulin. So we let's appreciate the events that are happening. So insulin is produced by the beta cell. So that what we saw was the beta cell, beginning from the translation of the insulin by RNA by the ribosomes attached to the endoplasmic reticulum to form the pre-proinsulin. So the ribosome, we expect there to have some amino acid. And how will they be organized? They'll be organized depending on the code that the RNA will just relay. So definitely we'll see some pre-proinsulin formed. So the pre-proinsulin will be formed. This will be packed along the Golgi body, and as it is being packed, it can be modified to form the proinsulin. So the proinsulin normally consists of 3 peptides. So we have the peptide A, B, C. So all these are very important. So most of this proinsulin is further cleaved down in the Golgi body apparatus to form insulin. So by the time you're having a secretory vesicle, the secretory vesicles are containing the insulin that ought to be released. So the insulin now containing the A and B chain, while having another C peptide that is cleaved off. So we can see this at this image over here. So this is a representation of the proinsulin. We are having 3 chains, the A chain, the B chain, and the C chain. So what you are able to see is that the A chain and the B chains are joined by the 2 disulfide bond. So over here. But again, they can be joined indirectly by the C peptide. So whereby if you continue your A chain along this line, it is in continuation to the C peptide that joins the B peptide. So the proinsulin seems to be like a one long chain. So in the packaging process, this can be cleaved off. And you end up now with the C peptide that has been cleaved off, and with the insulin. So insulin is composed of 2 chains. That is the A chain and the B chain. So the C peptide is also very important, especially when it comes to the laboratory test, because you cannot directly measure the level of insulin in the bloodstream. This is because we have an enzyme by the name insulinase that has the ability to cleave this insulin. So in some clinical circumstances where you'll be interested to find out the level of the insulin, so what you just measure is the C peptide, because from the image you are able to see what is happening. C peptide is released with insulin at a ratio of 1:1, because 1 proinsulin gives us 1 C peptide and 1 insulin. So if this insulin is being disintegrated prematurely, the C peptide is likely to be there. So we can use the level of C-peptide to indirectly determine the amount of insulin in the blood, because it will be more practical if you are maybe dealing with somebody with diabetes or maybe with hyperglycemia. So you want to establish if they are dealing, if these patients are having low level of insulin, or maybe if they are having normal level of insulin that are not responsive. So this could be the best way of classifying something as either resistant or insulin deficiency. So even though you might not be able to measure the level of insulin directly, you will rely on the C-peptide. So that's why they are important, at least clinically. The type of hormone, the type of enzyme that is likely to readily clear our insulin, we've suggested that this is known as the insulinase. So this makes it almost impossible to be able to check the level of insulin. So this is to say that when insulin is secreted into the blood, it normally circulates entirely in unbound form. It has a plasma half-life of an average of around 6 minutes, so it's mainly cleared from the circulation within 10 to 15 minutes. For this reason, it is difficult to check the direct level of insulin. Alternatively, you can use the C-peptide level on the radio immunoassay. So the C-peptide, of course, will be able to link that to the level of insulin because they are produced in the ratio of 1:1. So that is with the insulin production or with the insulin synthesis. So what we were suggesting with the protein polypeptide type of hormones is that most of the time we'll have our hormones already formed. They are just there in the secretory vesicle, awaiting for the appropriate stimulation so that they can be released. So the same is true when it comes to insulin because it's also a polypeptide and a protein in nature. So let's explore how the insulin is likely to be released. And it is from this that you'll be able to see maybe how the other oral anti-diabetic agents can act, because some act to increase the level of insulin production, some act to improve their sensitivity, and many other just to directly control the level of glucose. So how is the beta cell likely to produce the insulin? So from what we know, we know that insulin, for insulin to be produced, we need the glucose to be there. So glucose somehow stimulates the beta cells so that we end up with the insulin release. So let's just specifically describe what normally happens in the beta cells. So between glucose getting into the beta cells and insulin secretion, so what will happen? What we know is that glucose is very important for the insulin to be produced. So the secretion of insulin from the beta cell is normally regulated by chemical, hormonal, and neuronal mechanism. Insulin secretion occurs in two phases, namely a brief first phase in 2 minutes and a more sustained second phase. So the chemical way. So that means the beta cells should have a mechanism of sensing the glucose, and they have a specific transporter. So those are the GLUT2 or the glucose transporters that is able to incorporate glucose into the cells. So let's just go straight into the image. We are able to see that. So this is a representation of the beta cell. And let's say that this is now the bloodstream. So when the level of glucose increases in the bloodstream, it means that glucose can get into the beta cells by a facilitated diffusion. Facilitated, this is because we are using specific channel. This channel are GLUT2 or the glucose transporter. So these are insulin independent. They do not rely on the insulin for glucose to get into the cell. So once glucose gets into the cell, it is normally acted upon by an enzyme called the hexokinase or the glucokinase, to form the glucose 6-phosphate. So maybe what you need to know, you should just ask yourself, why should the glucose enter into the cell? And the simple answer will be, glucose needs to get into the beta cells to be utilized maybe through glycolysis and every other process, the Krebs cycles, electric phosphorylation, so that it produces some ATP. So we just want the glucose for the energy. Glucose gets into, utilized by the body to produce some ATP. And maybe you can ask yourself another question, why is the glucokinase very important? The glucokinase is very important in that it normally attaches some phosphate to the 6-carbon of the glucose. When this happens, it prevents the back diffusion of glucose into out of the cells because when the concentration shifts, the glucose can get out, or they have the tendency to leak out. So once they are attached to the glucose phosphate, they are not able to leak out. So this enhances the retention of glucose within the cell, within the beta cells. We've suggested the main reason why glucose need to get into the cell, it is because we require it to produce some ATP. So the beta cells uses it to produce some energy in form of ATP. So the ATP is normally utilized by potassium channel. So we are able to see the potassium channel. So under the presence of the ATP, the potassium ATPase is able to cleave this ATP so that it releases an energy. This energy can be used by this channel to close. So for this channel to close, it actually requires some ATP. So without the ATP, it will be something like this, allowing a lot of potassium to get out. And when the potassium gets out, it means that the cells become more and more negative. But in contrary, now that we have the ATP, the channel is able to close. So that means the amount of potassium that is getting out is greatly reduced. So that means the cell is likely to be much positive. So when it is getting positive, we'll say that the cell is being now depolarized. The depolarization is very important. This is because we have a specific calcium channel gates that are normally voltage dependent. Voltage dependent mean that at a specific voltage, they normally open or close. So a good example will say that, let's say maybe for a specific cell, their charge is normally at -60. But when the cell is retaining a lot of potassium, the cell becomes depolarized and becomes more and more positive. So at around maybe -40, this voltage dependent calcium channel can open. So when they open, a lot of calcium gets into the beta cells, as we are able to see over here. Of course, when the calcium cells gets into the cells, they will be having more and more depolarization. But the specific role of calcium is not to further depolarize the cell. The calciums we want to use the calcium as some cofactors. Cofactors to be able to activate a very important group of protein. For lack of name, let's use protein kinases. So when calcium gets into the cells, they are able to activate the protein kinases. So when the protein kinases are activated, what do? They'll be able to encourage the phosphorylation. The phosphorylations allows these vesicles to be able to change in a manner that they can insert themselves into the mother membrane, or rather the beta membrane, so that we have something like this. Allowing this substance retain within the vesicles, in this case insulin, to be released via exocytosis. So this is very important. You understand the glucose entry. What are some of the things that influences this glucokinase? We'll be able to see maybe there are some specific disease processes that are suppressing this, some specific drugs, some acting via the ATP, some acting via the calcium, directly closing it, directly opening it, and some, of course, via the potassium channel. So you just need to understand the specific pathway. What we knew, or what we might have known, glucose definitely will stimulate the beta cells to produce the insulin, but how does it do that specifically? So this is the pathway that we've just suggested, and that is the chemical, and by far it will be the most important chemical, suggesting that when the level of blood glucose increases, insulin secretion increases. And how does it or how does that occur? We'll just explain that particular process. So some other hormones, such as growth hormone, corticosteroids, and thyroxine, can also be very important in the release of these hormones. So for the hormone, I want you to think of the protein kinases that we've just mentioned. So whether they are active or not, they are likely to be influenced by hormones such as thyroid. The thyroid hormones. So these are the T4 and the T3. So remember, the T3, T4, they can encourage the protein synthesis. So some of the protein synthesis, some of the proteins that are being synthesized could also be enzymes. So remember, enzymes are protein in nature. So all the enzymes that we saw, the exokinase or the glucokinase, the ATPases that are required to break down the ATP, the protein kinases. Without the thyroid hormone, without the growth hormone, this might be depressed, and to a level, this will affect of course, the insulin production and the secretion. We also have the neuronal stimulation. So the neuronal stimulation could be having a dual effect. The islets are well supplied by the sympathetic and the vagal nerves. So that means they have some beta influence, beta alpha, and also some acetylcholine influence, or the muscarinic influence. So specifically with the sympathetic, where we can have two types of receptor, both alpha and the beta. So the islet is well supplied by the alpha and the beta. So what happens when you stimulate the alpha? So stimulation of the alpha 2 receptor decreases the insulin release by inhibiting the beta adenyl cyclase. While if the same hormones, the same neurotransmitter stimulates the beta 2 cells, increases the insulin by stimulation of the adenyl cyclase. So something like epinephrine might have a dual effect, can somehow suppress and stimulate at the same time. So this translates to maybe not having too much effect of on the insulin, because we are having two opposite effects. So what about with the vagal, or rather with the acetylcholine? So acetylcholine can be able to act on the cholinergic muscarinic. This will cause the insulin secretion through increased intracellular calcium in the beta cells. So most of the neuronal stimulation activates the insulin. So whether beta, whether through sympathetic can have a dual effect, depression and secretion, while for the parasympathetic is definitely increasing the amount of insulin that should be there. So why is that last statement very important? So in your clinical scenario, just imagine a clinical scenario where you could be having an heightened parasympathetic state, either by drug toxicity or maybe by the clinical circumstances, or an heightened sympathetic state. How is this likely to translate, or rather, how is this likely to affect the level of glucose? So even though generally you'll say that the sympathetic is also likely to increase the level of insulin, not the level of insulin, but the level of glucose. This is because apart from the pancreas, it can also act on the liver to be able to encourage the breakdown of glycogen, and this will give us a lot of glucose. So we might see some dual kind of effect. So once you've had your insulin released, they need to act on the specific receptors. So the insulin receptors are very important or very unique receptors. So these are normally referred to as the enzyme linked receptors. So if you can be able to see at the image where you are having the receptor, so this is a receptor. They are linked to an enzyme internally. So that means that if insulin receptors are stimulated or activated, they'll be able to directly stimulate other types of enzyme. So a good example is a tyrosine kinase, which when stimulated, it will be able to influence a group of enzymes, which will be able to control a lot of the metabolic processes, metabolic stroke physiological processes. So this is an insulin receptor. Normally has two sides. So we have the alpha that should be interacting with the receptor, and we have the beta that normally embeds. It's normally embedded on the cell membrane, internally attached to an enzyme, a tyrosine kinase. The alpha and the beta are joined by the disulfide bond. So when this is stimulated by the insulin, tyrosine kinases will be activated, and this will activate a group of enzymes referred to as the insulin receptor substance phosphorylation of enzyme. So when these are activated, they are able to control many processes. One particular processes that we are interested in, specifically with the diabetes, it is that it is able to control the glucose transport. So this is of course through some glucose channel, the GLUT. So which type of GLUT? The GLUT which are insulin dependent. So that means that minus the glucose, this type of glucose channel will not open, and if they don't open, I will have a lot of glucose in the bloodstream. So this type of glucose transport are normally predominant in areas such as the muscles and the fatty cells that should be able to utilize to absorb and utilize a lot of glucose in the bloodstream. So the specific GLUT that is normally insulin dependent is referred to as the GLUT4. So we have GLUT1, GLUT3, GLUT2, GLUT3 that are normally insulin independent. So they'll just open even if there is no insulin. But for the GLUT4, the insulin needs to be there for it to open. So there's some specific long process that will partake that that can occur so that we have our insulin, our glucose channel opening. And how is that likely to happen? Of course, when the tyrosine kinase is activated, there'll be some specific phosphorylation that will allow this to open. So you should be able to remember that. And the insulin, it's not only important in the glucose, it also influences the protein metabolism, the fat metabolism, the glycogen, and of course level of growth. So this is what we've suggested. Once the insulin attaches to their receptor, they are able to stimulate the tyrosine kinases that in turn stimulate a group of enzymes that is able to give us now the specific metabolic and physiological processes. So example of such could be amino acids. The cells becomes more permeable to amino acids. They can be able to get in potassium, phosphate, and of course glucose. So maybe if you've covered this in your internal medicine, you should be able to see why maybe insulin again can be a therapeutic modality in situations that present with hyperglycemia, hyperphosphatemia, hyperkalemia, and some other metabolic syndrome. In that, if you give insulin, a lot of this will be absorbed into the cells so that the level reduces in the bloodstream. Because if you have a lot of phosphatemia, it will present with other metabolic compromise, similarly to potassium, that might affect largely the cardiovascular role, of course, the specific role of the heart. So let's examine the effect of insulin on different macromolecules. So for example, we have the carbohydrate metabolism. So insulin is very important. How will it affect the carbohydrate metabolism? So you should be able to note this. Insulin will promote the glucose uptake, of course, using the GLUT4 as we've suggested. Insulin promotes the liver uptake, storage, and utilization of the glucose. So this is by insulin inactivates the liver phosphorylase. The phosphorylase is very important in the breakdown of glycogen. So that means it prevents the further breakdown of glycogen into glucose. And of course, what will this be doing? It will be limiting the amount of glucose that is available in the bloodstream. Insulin also enhances the uptake of glucose. We've been able to mention that. This is by also encouraging, or rather activating, what we call the glucokinase. So this will prevent the the glucose from getting out of the cells. So insulin also increases the activities of enzymes that promote the glycogen synthesis. So if you are able to remember the glycogenesis, there are a lot of steps that were assisted by various enzymes. So the enzymes can be activated by the insulin. So insulin also promotes excessive conversion of glucose into fatty acids and inhibits gluconeogenesis. So we've been suggesting that if you have excessive level of glucose, some will be converted into glycogen. If the level further increases, of course, an excess amount of it needs to be converted into fatty acids. So that can be aided by the insulin. And of course, for the transport that you are specifically focusing on is with the glucose transport, normally aided by the GLUT4. So this is to suggest that normal cells that normally takes glucose and they are dependent on insulin, they normally have their GLUT4 receptor just on the cytoplasm. But once these cells have been activated by insulin, so these can be translocated and attached into the membrane, forming a pore. So this pore becomes the GLUT4. So insulin stimulates a cell, allowing the GLUT4 to translocate from the cytoplasm into the cell membrane. So this is how the insulin is likely to increase the permeability of the cells to glucose. And of course, most of these GLUT normally have some what you can call the core transporter mechanism. So that is they can also allow things like sodium to pass alongside. So those are the specific co-transporter mechanism for the sodium that can also allow glucose to get in. So apart from glucose, insulin is also very important when it comes to fat and protein. Specifically, insulin is likely to promote fat synthesis. When you are promoting fat synthesis, it is basically utilizing the amount of glucose that are there in excesses and converting them into fat, and of course storing them. And then when we'll require them in the future, we'll see a reversal of the process. So apart from the fat, it also stimulates the transport of several amino acids into the cells. So these are valine, leucine, isoleucine, tyrosine, and phenylalanine. And maybe what this can mean is that insulin can be very important in a growth process, because for growth to occur, we also require a cell to receive a lot of amino acids, which will serve as a raw material for the protein synthesis. And that is exactly what is happening. Insulin is able to allow amino acids to get into the cell, and it's able to utilize a lot of glucose to be converted into the fatty cell, into fats. So that could be obvious clinically. I know you've maybe interacted maybe with type 1 diabetes. So one of the features for these people is that these people tend to be a little bit thin. So this you can translate them chemically to maybe mean that you are not promoting fat synthesis, and of course you are not incorporating a lot of amino acid. So this is in relation to cell. So this is likely to translate into the thin characteristic that you normally see with this individual. So insulin again is very important for other metabolic processes. This is because insulin increases the translation messenger RNA, thus forming new proteins in some unexplained way. Insulin turns on the ribosomal machinery. So this is another mechanism with which it can affect the protein metabolism. Remember, for the protein to be synthesized, the DNA translation is very important. So it is also hypothesized that insulin can also be able to increase that translation mechanism. And of course, that's why it becomes important for growth. Again, this is consistent with maybe somebody being thin. And if these people were diagnosed with diabetes at a very tender age, or they've been diabetic at a very tender age, their growth might be retarded, because for growth to occur, we actually require proteins. So over a long period of time, insulin also increases the rate of transcription of the selected DNA processes. All this likely to translate into growth and specific metabolic mechanisms that are required in the body. So the specific DNA genetics, you might want to think of this as maybe an example could be the enzymes that are necessary for the glycogen production. So the enzymes are also proteins in nature that require translation and transcription. So insulin is able to control the specific transcription to this process, translation, so that we get the appropriate enzymes. So not ignoring that we are ignoring, the other hormones. The other hormones, of course, will be able to see those that can again affect the transcription and the translation processes. Insulin again is it's able to inhibit the catabolism. So we are not only making protein, but we are also ensuring that we are reducing the breakdown of the proteins from the cells, specifically from the muscle. So we don't expect these people to be emaciated. So any question? Any question? So we have various types of diabetes mellitus. So this mostly directly relates to the insulin production and of course their action. So we have the type 1 diabetes mellitus. This is normally result from the selection of beta cells distractions, which present with severe or absolute insulin deficiency. So remember, the beta cells will be producing the insulin. So diabetic type 1 normally represented by when the insulin are not being produced. It could be because of the destruction of the beta cells. So the patients normally require insulin to survive. This is because they are either producing low amount of insulin or the insulin is not there at all. So the only way for these people to survive is for you to give them some insulin. We also have type 2 diabetes. So this is normally characterized by resistance to the action of insulin. So the insulin can be there, but maybe not acting adequately. So this used to be referred to as the non-insulin dependent diabetes mellitus. But now this term is misleading. This is because if you are type 2 diabetes, after long duration with a lot of glucose in the bloodstream, so this glucose sometimes tends to glycate with the remaining beta cells, and the glycation might be translated into destruction. So with the time, this type 2 diabetes transitioning into insulin dependent. So that's why the insulin dependent and the non-insulin dependent can be misleading. So you rather just say type 1 diabetes and type 2 diabetes, because type 2 diabetes, if it is mismanaged or if people are not adherent to their drug, can transition into insulin dependent, where these people cannot do or cannot survive without insulin. So we also have other classification in terms of diabetic mellitus, even though not official. Type 3 describe the multiple other specific causes of elevated blood sugar, non-pancreatic diseases, or maybe as a result of drug therapy. So this could be we'll be able to see maybe how steroids, how the growth hormone might also increase the level of blood sugar without necessarily affecting the pancreas. We also have the type 4. Type 4 can be referred to as gestational diabetes, which is abnormality in glucose level that is noted for the first time during pregnancy. So when you want to treat diabetes, our main aim is actually to control the glucose. And how will you control the glucose? Of course, this can be achieved by drugs. It can be achieved by diet. We also want to alleviate the symptoms of hyperglycemia and improve the quality of life, and while at the same time avoiding the disabling hypoglycemia. So the bad thing is that with our drugs, either the oral anti-diabetic drugs and with the insulin, our major feared side effect is normally the hypoglycemia, which if not treated, it can result into death. So while giving the drugs, you are also keen on controlling this. So should it happen, you should be having a mechanism of quickly restoring the normal level of glucose. So maybe a patient could be having some glucose just in case, or some chocolates just in case, because you are not likely to cure diabetes. Your main aim is actually to prevent the complications that normally relates to diabetes. So you want to prevent your diabetes mellitus from worsening and possibly avoid the complications. You and the patient should be able to know this. This is because if the patient thinks that the drug that you're giving them might be able to cure the diabetes, they are able, after some time, they can default the drug especially when the RBS and the FBS are well controlled, not knowing that the drugs should just be there to suppress the level of sugars and not really curing the disease. The obvious acute complications are infections and the ketosis. This again is our business while using the anti-diabetic drugs. So